Welcome to the deep dive. Today we're tackling something really critical, vascular trauma. We've been digging into section 28 of Rutherford's Vascular Surgery and Endovascular Therapy, specifically chapters 179 through 184.
Yeah, it really reads like an essential field guide,
Yeah.
for surgeons dealing with these high-stakes situations.
Exactly. Like the instruction manual you hope you have when things go sideways with blood
Yeah,
vessels.
absolutely. Because vascular trauma, well, whether it's civilian life, a car crash, or on the battlefield, it's immediately life and limb threatening. Massive bleeding, loss of limbs.
Understanding how to manage it is just non-negotiable for a vascular surgeon.
Totally.
And looking back, the progress is pretty amazing, isn't it? The book points to the Korean War as like a major shift.
Oh, definitely. That's when surgeons really started attempting primary repairs more often. Before that, ligation, just tying off the vessel, was much more common, especially in World War II.
And the outcomes improved quite a bit, apparently. Plus, that move away from cadaver grafts.
Right, to using the patient's own veins, autologous vein grafts. That was huge.
Why was that so significant? The autologous part.
Well, two main things. One, your own tissue doesn't get rejected, obviously. And two, vein grafts tend to stay open, patent much longer than the older options. It really opened the door for more durable repairs.
Makes sense. And now, modern management is, well, it's a whole different ballgame, right? We've got temporary shunts.
Yep, to keep blood flowing while you fix things or deal with other injuries.
Routine fasciotomies.
Crucial for preventing compartment syndrome, that dangerous pressure buildup in the muscles.
Negative pressure wound therapy.
Great for managing those messy soft tissue wounds that often come with these injuries.
And, of course, all the endovascular stuff.
Yeah.
Treating from inside the vessel.
Each one of those is a major leap. Shunts buy time, fasciotomies save limbs, Endotech offers less invasive options. It's quite an arsenal now.
The book does make a good point, though, about comparing outcomes over time. Like, comparing today's conflicts to, say, Vietnam or Korea, it's tough.
It really is. The weapons are different, protection is different, so the injury patterns change. And critically, pre-hospital care is way better. People survive injuries now that they wouldn't have before.
So you're seeing a different, maybe more severely injured group actually making it to the hospital.
Exactly. Which makes those historical comparisons tricky if you don't account for all that.
But it's still pretty sobering that even with all this tech, hemorrhage major bleeding is still a huge killer in recent conflicts, like in Iraq and Afghanistan.
It absolutely is. Controlling massive hemorrhage, especially in the torso, remains a massive challenge.
And the text mentions that the standard ways we score injuries, like the ISS or TRIS scores, don't always capture how bad a major vascular injury really is.
Yeah, they're good for overall trauma severity, but they kind of lack the granularity for the specific impact of, say, a torn aorta or femoral artery. The physiological consequences are just different.
It mentions the ASOIS system, which is more specific for organ injuries, and scores for mangled limbs, like MES-S.
Right, the mangled extremity severity score. Those help.
But even they aren't perfect predictors of whether a limb can be saved, are they?
No, not perfect. They're useful inputs, definitely, but there's still so much that comes down to the patient's overall state, the collateral circulation, how fast you intervene, and, frankly, surgical judgment. It's not just a numbers game.
Okay, shifting to civilian trauma. Less common than in combat, but the book hints the numbers we see are probably lower than reality.
Likely an underestimate, yeah. And interestingly, similar rates in the very young and the elderly, but more common in men.
And the causes are different too, right? Especially in older folks.
Yeah, in the geriatric population, it's mostly blunt trauma, car accidents, falls, and blunt thoracic aortic injury, BTAI, that's a big one you see there.
And the natural history idea, how these injuries progress, if left alone, that's interesting. Some seem minor but get worse. Others might just heal.
Exactly. It's not always obvious up front. A small tear, a laceration, might balloon into a pseudoaneurysm or just clot off thrombose. A bruise, a contusion can lead to narrowing stenosis down the line.
AV fistulas can grow.
Right, those artery vein connections and those blunt intimal tears, those inner lining flaps. Some resolve, some dissect further or thrombose, needs careful watching.
And that brings us to non-compressible truncal hemorrhage. Bleeding deep in the chest or belly you just can't press on.
Extremely dangerous. Injuries to the big name vessels there, aorta, vena cava, iliacs, they carry incredibly high morbidity and mortality. Even in kids who usually bounce back better, unstable thoracic vascular injuries are often fatal. It really highlights the difficulty of controlling that kind of central bleeding.
Okay, so let's get into the specifics, starting with the neck, chapter 180. Cervical vascular injuries. Sounds complex right off the bat.
It is. Tight space, lots of vital structures packed in there, nerves, airway, esophagus, plus associated injuries are common.
And they use those neck zones, RS 2 and 3rd, to help manage penetrating injuries, right?
Yeah.
Stabs, gunshots.
Correct. Zone 1 is low down, near the collarbones. Zone 2 is the mid-neck, easiest to access surgically. Zone 3 is high up, near the base of the skull, much trickier. It helps guide the workup and the surgical approach.
The first big decision point seems to be, does the patient have hard signs?
Absolutely. If you see pulsatile, squirting blood, or a rapidly expanding hematoma, or feel a thrill, hear a bruit, those are hard signs.
And if you see those?
Straight to the OR. No delays for imaging. Time is critical to stop the bleeding.
But what if they're stable? No hard signs. Maybe just some soft signs like proximity to the wound track.
Then you have time for imaging. And these days, CT angiography, CTA, is really the workhorse.
It's pretty good at finding injuries.
Very good. High sensitivity and specificity gives you great anatomical detail. The main limitation is artifact from bullet fragments or bone chips, which can obscure things.
And if CTA is unclear because of that?
Then you might move to traditional catheter-based arteriography for confirmation. Ultrasound has a more limited role, maybe helpful in Zone 2 sometimes.
Surgical approaches differ by zone then. Zone 2 is more straightforward.
Generally, yes. A standard neck incision usually gives good access. Zone I might require extending into the chest, and Zone 3, that's tough. Getting control high up near the skull base is challenging.
The book mentions Fogarty balloons for distal control in Zone 3.
Yeah, threading a balloon catheter past the injury to inflate it and temporarily stop bleeding from further down. It's a useful technique when you can't get a clamp on easily. Then, after you control the hemorrhage up there, you decide. Direct repair, maybe bypass, endovascular options like stenting or coil embolization, or even just shunting as part of damage control.
Okay, shifting gears within the neck. Blunt cerebrovascular injury, BCVI, damage to carotids or vertebrals from blunt force, not penetration.
Right. And this is something we're much better at recognizing now, mostly thanks to better, more routine imaging in trauma. A key point is that many BCVI patients have no symptoms initially.
That's worrying. So how do you pick them up?
Screening. We use criteria, like the Denver or Memphis criteria, looking for specific injury patterns or signs.
What kind of things trigger screening?
Things like certain types of neck fractures, especially involving the bony canals the arteries run through, base of skull fractures, near-hanging injuries, neurological signs that don't match CT head findings, Horner's syndrome, a whole list of indicators.
So high index of suspicion based on mechanism and associated injuries.
Exactly. And for diagnosis, again, CTA is now widely accepted as the primary screening tool. It's not quite as sensitive as the old gold standard DSA digital subtraction angiography, but 16-slice or better CTA is very good and much less invasive. MRA isn't typically used in the acute setting.
And if you find a BCVI, say dissection or a pseudoaneurysm in the carotid, what's the treatment plan?
The mainstay is medical management with antithrombotic therapy. The goal is to prevent stroke from clots forming at the injury site or breaking off.
So blood thinners, heparin, antiplatelets.
Yes. Typically starting with heparin and maybe bridging to warfarin or using antiplatelet agents like aspirin or clopidogrel. There aren't huge randomized trials, but strong observational data shows it reduces stroke risk significantly compared to no treatment.
But there's a risk of bleeding with anticoagulants, especially in trauma patients.
Always a balance, yes. You have to weigh the stroke risk against the bleeding risk from other injuries. The type and grade of BCPI also play a role.
And you need to follow these injuries closely with imaging.
Absolutely critical. Repeat CTA or DSA, often around 7-10 days, and then maybe again at 3 months, to see if the injury is healing, stable, or worsening. Lower grade injuries often heal well. Higher grade ones, like pseudoaneurysms, are less likely to resolve spontaneously.
And for those higher grade ones that don't heal, endovascular options.
Yes, particularly for pseudoaneurysms. Covered stents can be deployed across the injured segment to essentially exclude the pseudoaneurysm from circulation. It's especially useful for injuries high up in the internal carotid, near the skull base, where open surgery is very difficult.
Any downsides to stenting?
Potential complications like stent thrombosis clotting inside the stent exist, though they're less common now. And these patients need lifelong surveillance, usually with imaging and antiplatelet therapy.
When would open surgery be the answer for BCVI?
It's less common now, but might be considered for injuries that are worsening despite medical therapy, enlarging pseudoaneurysms that aren't suitable for stenting, or maybe accessible injuries lower down in the neck, particularly if the patient can't be on long-term anticoagulation. Again, location and patient factors drive the decision between open and endo.
What about the vertebral arteries, also susceptible to blunt injury?
Yes, though less common than carotid BCVI, often associated with those transverse foramen fractures in the cervical spine. A key difference is that unilateral vertebral injury is often asymptomatic because the other vertebral artery and collateral circulation can usually compensate.
Diagnosis is similar, CTA.
Yes, primarily CTA now. Interestingly, for vertebral injuries, the injury grade doesn't seem to correlate as strongly with stroke risk as it does for carotid injuries. The risk seems to be around 20% regardless of grade, which argues for treating most significant vertebral injuries.
And treatment, endo again.
Endovascular approaches are common here too. Covered stents for pseudoaneurysms, lacerations, fistulas. Coil embolization might be used to block off a damaged segment if the other vertebral artery is healthy. Access can be via the leg or the arm.
And quickly, neck veins, mostly penetrating trauma.
Mostly penetrating, yeah. Often found when exploring for an associated arterial injury. Bleeding can be significant, but usually lower pressure and easier to control surgically than arterial injuries. Ligation or simple repair are common options.
Okay, let's move down to the chest. Chapter 181, thoracic vascular trauma, big vessels, high stakes.
Extremely high stakes. While most chest trauma patients, thankfully, don't need surgery, if a major vessel like the aorta, innominate, or subclavian is hit, mortality skyrockets.
So initial assessment is ATLS driven. Find and fix the immediate life threats.
Always. Airway, breathing, circulation first. A good physical exam is key too, looking for things like unequal pulses or blood pressures between arms, listening for bruits, checking for expanding hematomas at the base of the neck. These can be clues to underlying vascular injury.
Imaging starts with a chest x-ray, but as we said, it's not great for picking up aortic injuries, right?
It's a screening tool. A widened mediastinum is suggestive but non-specific. Hemothorax might be missed on supine films. Really, for the stable patient you suspect might have a major vessel injury, CTA is the standard now.
CTA gives you the detailed picture.
Absolutely. 3D reconstructions, good views of the aorta, pulmonary arteries, major branches. It's revolutionized diagnosis. Sometimes, if the CTA is maybe equivocal or there's blood around the aorta, IVUS intravascular ultrasound can be helpful.
IVUS. Inserting an ultrasound probe.
Yeah, right into the vessel, gives a direct look at the wall, no contrast, no radiation, but it's invasive, needs a bigger sheath, adds cost. Angiography's role has shifted more towards therapy now.
Less diagnostic, more interventional.
Pretty much. Still vital for planning and executing endovascular repairs, but less often the first step for diagnosis alone.
And there are clear times when you just have to open the chest immediately, right?
Oh, yes. Indications like massive air leak suggesting a tracheobronchial injury, cardiac tamponade, ongoing massive hemorrhage from the chest tubes. Those require emergent thoracotomy or sternotomy.
Let's focus on blunt thoracic aortic injury, BTAI. Sounds like a big topic.
It is. It's a leading cause of death after major blunt trauma. Think high-speed car crashes, falls from height. The aorta tear usually just past the takeoff of the left subclavian artery, the isthmus.
But outcomes are better now because of TAVR.
Dramatically better, yes. Thoracic endovascular aortic repair TAVR has largely replaced open surgery for suitable BTAI patients. It involves placing a stent graft across the tear from inside the aorta, usually via the femoral arteries.
And it's generally preferred now.
Yes. Guidelines from the Society for Vascular Surgery favor TAVR due to significantly lower mortality, less risk of paralysis, kidney injury, and shorter recovery times compared to the traditional big open operation.
But people with BTAI don't always present in shock.
Correct. Some are hemodynamically unstable, but others can be surprisingly stable initially, maybe just with some concerning findings on chest x-ray or mechanism of injury. That's why CTA is so crucial for screening.
Diagnosis relies heavily on CTA then, and how are these injuries classified?
They're graded based on the depth of injury through the aortic wall. Grade 1 is just an intimal tear. Grade 2 involves the media, maybe with a hematoma in the wall. Grade 3 is a pseudoaneurysm-contained rupture. Grade 4 is free rupture. The Starnes classification is a simpler version. Minimal, grade 1, small 2. Moderate, larger, grade 23. Severe, grade 4, large 3. This helps guide treatment.
What's the immediate first step when BTAI is diagnosed?
Anti-impulse therapy. aggressively controlling blood pressure and heart rate, usually with beta blockers and maybe other agents, to minimize stress on that injured aortic wall. This is started immediately.
Is that sometimes the only treatment needed for minor injuries?
For grade 1 injuries, yes, medical management alone is often sufficient, with close imaging follow-up. There's also growing evidence and debate about non-operative management for some minimal grade 2 injuries too, especially if the patient has other severe injuries, like a bad head injury.
But for more severe injuries, repair is needed. When? Immediately.
Prompt repair is generally preferred, within 24 hours if possible, for grades 2 before. But sometimes if the patient has other life-threatening injuries, like intracranial bleeding, a selective delay in aortic repair might be safer, continuing strict medical management in the meantime. It's a complex decision.
And a repair is usually PVAR these days.
For most patients with suitable anatomy, yes. The first FDA-approved device was around 2005, and now there's several options. The outcomes data favoring TVAR over open repair is quite strong.
What did open repair involve? Sounds major.
Yeah.
It is. Usually a large incision on the left side of the chest, thoracotomy. Techniques varied. Some surgeons would just clamp the aorta above and below the tear and sew it, clamp and sew. Others use distal perfusion techniques like left heart bypass to protect the spinal cord and organs, or even full cardiopulmonary bypass. High morbidity.
So TVAR avoids all that.
Largely, yes. Access is through the groin arteries. Post-op involves close hemodynamic monitoring, watching for complications.
What are the potential complications with TVAR?
The main ones are endoleaks, persistent blood flow into the aneurysm sac around the graft, stent-graft migration, access site problems like bleeding or vessel injury, but these are becoming less common with better devices and more experience. Neurologic complications like stroke or paralysis are much lower than with open repair.
So overall, TVAR has made a huge difference in survival and outcomes for BTAI. What are the big remaining questions or controversies?
Key areas include the best management for those minimal grade 2 injuries, operate, stent, or watch. Optimal timing of repair in patients with both BTAI and significant traumatic brain injury, balancing bleeding risk versus stroke risk, and the long-term durability of these stent grafts in young trauma patients. We need more data, which is where registries like PIRO-OV come in.
The chapter also covers other thoracic vessel injuries. Innominate subclavian.
Briefly, yes. These often require different surgical approaches, like a median sternotomy, splitting the breastbone, or combined neck and chest incisions. Bypass grafts are frequently needed. Endovascular techniques, like covered stents, are increasingly used for these injuries too, often with good early results, but again, long-term data is still needed.
Okay, let's move out to the limbs. Chapter 183, Extremity Vascular Trauma. Life and limb thread again.
Definitely. The goals are simple: stop the bleeding, restore blood flow, but achieving them can be complex. And as you mentioned, long-term functional outcome data from civilian studies is often lacking.
What factors make amputation more likely?
Several things increase the risk. Blunt trauma tends to be worse than penetrating. Associated severe bone and soft tissue damage, more proximal injuries like femoral or axillary artery injuries, damage to both arteries in the forearm or multiple tibial vessels, and popliteal artery injuries behind the knee historically have very high amputation rates. Also, trying to reconstruct arteries way down in the calf has a higher failure rate.
Identifying these injuries quickly is key. What about those hard and soft signs we discussed for the neck? Do they apply here?
They do, but again, CTA has changed things. Hard signs, active hemorrhage, expanding hematoma, absent distal pulses, cold pale limb, palpable thrill or audible bruit still strongly suggest a major injury needing urgent attention, often surgery. Soft signs, history of bleeding, diminished pulses, nearby nerve injury, proximity of penetrating wound raise suspicion, and usually warrant further investigation, typically with CTA.
So if the patient's stable, CTA is the way to go.
Generally, yes. For both penetrating and blunt injuries where vascular trauma is suspected, it shows you the arteries, bones, muscles, everything. Very high sensitivity and specificity now. A simple Doppler exam at the bedside to check for signals, and calculating the ankle brachial index or injured extremity index can also give quick, useful info about perfusion.
Okay, management principles. Damage control is mentioned first. What does that involve?
For the most severely injured, unstable patients, it means doing the minimum necessary initially to control bleeding and restore basic perfusion, often with temporary measures, allowing time for resuscitation before attempting definitive repair. Think tourniquets, shunts, packing.
Let's talk tourniquets, still a mainstay.
Absolutely, especially for hemorrhage control below the trunk. Proper application is key, converting to an operative tourniquet if possible, and being aware of time limits to minimize nerve and muscle damage. For junctional hemorrhage groin, axilla direct pressure, specialized junctional tourniquets, or even endovascular balloon occlusion like Reboe for pelvic lower extremity bleeding are options.
And temporary shunting. Putting in a tube to bypass the injury.
Yes, very important. Restores blood flow distally while orthopedic injuries are fixed, or while the patient is stabilized in the ICU. More common for injuries above the elbow or knee. If both the artery and main vein are injured, shunting the vein first can sometimes help reduce swelling.
Fasciotomy comes up again here too.
Crucial in the extremities, especially with prolonged ischemia times, combined bone and artery injuries, or injuries known to cause significant swelling like popliteal or brachial artery repairs. Lower leg compartments are most susceptible. You have to release that pressure to prevent muscle death. Early consideration is key, but it does mean more wound care later.
Can some arterial injuries be managed without surgery?
Yes, sometimes. If CTA picks up a small occult injury like a tiny intimal flap or pseudoaneurysm that isn't blocking flow or actively bleeding and isn't likely to cause problems, observation with repeat imaging might be appropriate.
What about endovascular options in the limbs?
Definitely has a role. Useful for junctional vessel injuries that are hard to reach surgically. Balloon angioplasty or stenting for traumatic occlusions or dissections. Covered stent grafts can treat active bleeding, pseudoaneurysms, or AV fistulas in larger vessels. Embolization is good for smaller branch vessel bleeding, like from deep femoral or tibial branches.
But open surgery is still common.
Absolutely, especially for major arterial transections or complex injuries. The principles are standard. Get proximal and distal control. Make adequate longitudinal incisions for exposure. Repair the vessel often with a vein graft patch or interposition graft, and restore flow. Local heparidized saline irrigation is used if systemic anticoagulation is risky.
The chapter then goes through specific arteries. Axillary artery, armpit.
Yes. Injury here can be subtle. Distal pulses might feel okay due to collaterals. High suspicion needed with proximal humerus fractures or brachial plexus nerve injuries. Doppler, CTA, or angiography for diagnosis. Surgery requires careful dissection around the nerves.
Brachial artery, upper arm.
Similar diagnostic thoughts. Prone to spasm, also high risk for compartment syndrome after repair.
Radial and ulnar arteries in the forearm.
Pulse deficits are common here. The Allen test, checking flow from both arteries to the hand via the palmar arch, is essential. If one artery is out but the arch is complete, ligation might be okay. If the arch is incomplete or both are injured, repair is needed, usually prioritizing the ulnar artery.
Femoral artery in the thigh.
Common injury often causes obvious ischemia. Can involve the main superficial femoral artery, SFA, or the deep femoral artery, profundifemoris, PFA. PFA injuries, especially from penetrating trauma near the groin, might just present as a hematoma or pseudoaneurysm, so have a low threshold for CTA with groin wounds.
Popliteal artery behind the knee. Sounds like the bad one.
It carries the highest amputation rate, especially with blunt trauma, which often involves more associated tissue damage. Ischemia is almost always present. Duration of ischemia is critical. The longer the delay to reperfusion, the worse the outcome. Blunt popliteal injuries are particularly challenging.
And tibial arteries below the knee.
Often injured in combination. If the foot is ischemic, you need to restore flow through at least one tibial vessel. Repairing these small vessels is technically demanding, and vein grafts are usually required. Isolated tibial injuries can sometimes cause delayed pseudoaneurysms or AV fistulas, often treatable with embolization.
What about the mangled extremity? Severe combined injury?
That requires a multidisciplinary team, ortho, plastics, vascular. The goal is usually limb salvage initially, unless the limb is clearly non-viable or the patient is too unstable, life over limb. Scoring systems like MENES can help guide the decision, but aren't absolute.
And briefly, frostbite. Vascular surgeons get involved.
Yes, for severe frostbite. Freezing causes direct cell damage, but the subsequent thawing and reperfusion can lead to intense vasospasm and clot formation in the small arteries, causing distal gangrene. Catheter-directed thrombolysis clot-busting drugs delivered via catheter right into the limb's arteries can sometimes salvage tissue if done early, alongside standard warming and wound care.
Interesting. Okay, last chapter, 184. Repetitive trauma and occupational vascular problems. A different kind of vascular injury.
Right, not usually from a single major event, but from cumulative stress or repeated minor trauma, often work-related or recreational. These can cause significant disability and time off work.
The chapter mentions hand-arm vibration syndrome, HAVS, from using vibrating tools.
Exactly. Jackhammers, chainsaws, grinders causes vibration, white fingers turning white and numb, especially in the cold pain, tingling. Risk depends on vibration intensity, duration of exposure, frequency.
How is it treated?
Main thing is stopping the vibration exposure. Smoking cessation is critical. Calcium channel blockers can help with vasospasm. Severe cases with tissue loss might get prostanoids. Prevention with good gloves and limiting exposure time is key.
Then there's hypothenar hammer syndrome, HHS. Sounds painful.
It is
Ah,
caused by repetitive impact to the hypothenar eminence, the fleshy base of the palm on the little finger side. Think mechanics using their palm as a hammer, construction workers, etc. It damages the ulnar artery running through there.
leading to clots or aneurysms.
Yes, thrombosis or aneurysm formation in the ulnar artery, which can then cause hand ischemia, pain, coldness, ulcers, or send clots down to the fingers. Diagnosis involves a good exam, Allen test, often duplex ultrasound or angiography.
Treatment for HHS.
Avoid the trauma, protect the hand, stop smoking. Medications like calcium channel blockers or antiplatelets might help. Surgery bypassing the damaged segment with a vein graft, or sometimes ligation may be needed if symptoms are severe or there's an aneurysm.
The chapter also mentions other things like occupational acrosteolysis, electrical burns causing late vascular issues.
Yeah, and thermal injuries. Then it moves into athletic injuries causing upper extremity ischemia.
Athletes get vascular problems from repetitive motion too.
Absolutely. Especially overhead athletes like baseball pitchers, swimmers, tennis players. Can affect vessels anywhere from the subclavian artery down to the fingers.
Hand ischemia in athletes. From what?
Can be direct trauma to digital arteries. Think baseball catchers, martial arts, volleyball players, blocking spikes. Or it can be embolic clots forming further up, maybe due to arterial compression and traveling down to the fingers. Treatment ranges from rest and meds to surgery. Padded gloves help prevent direct trauma.
What about quadrilateral space syndrome?
That involves compression in a space in the back of the shoulder, can compress the axillary nerve, causing neurogenic symptoms, or the posterior circumflex humeral artery, causing vascular symptoms, thrombosis, aneurysm, emboli, especially in throwers. Treatment depends on whether it's nerve or artery, ranging from rest to surgery to ligate the artery or decompress the nerve.
And the humeral head itself can compress the axillary artery in throwers.
Yes, during the extreme motion of throwing, the artery can get pinched, causes arm fatigue, numbness, maybe Raynaud's. Diagnosis often needs dynamic imaging, like angiography with the arm in the throwing position. Treatment might involve modifying technique or surgical repair, like patch angioplasty or bypass.
Finally, arterial thoracic outlet syndrome in athletes.
Similar mechanism compression of the subclavian or axillary artery, but usually between the clavicle and first rib, often due to repetitive overhead activity leading to bony changes or muscle hypertrophy. Symptoms overlap with the humeral head compression. Diagnosis again involves positional testing and imaging. Treatment is usually surgical decompression, removing the first rib, releasing muscles.
Wow. A lot of different ways blood vessels can get injured, from massive trauma to repetitive stress.
It really covers the spectrum, doesn't it?
So, wrapping this up, this deep dive into Rutherford's on vascular trauma, it really highlights the complexity and the constant evolution in this field.
It really does. From understanding the basic mechanisms and natural history to applying these advanced diagnostic tools like CTA and sophisticated interventions, both open and endovascular.
And the progress is undeniable, especially with things like TVAR for aortic injuries, but challenges clearly remain. Controlling that massive hemorrhage, predicting limb salvage, managing those tricky occupational syndromes.
Absolutely. And the importance of timely diagnosis and intervention just comes through again and again as the key to good outcomes. Getting the right imaging quickly, making the right decisions about medical versus endo versus open management.
It also feels like there's still a lot we're learning, right? The debates around managing minimal aortic injuries, the long-term results of endo repairs, how best to integrate all these techniques.
Definitely. It underscores the need for ongoing research, for good registries like POVICI to track outcomes, and for surgeons to continually learn and adapt. It's not a static field.
And the multidisciplinary approach seems essential too, particularly for complex extremity trauma or thoracic injuries.
Couldn't agree more. Trauma surgeons, orthopedic surgeons, plastic surgeons, interventional radiologists, vascular surgeons, everyone has to work together.
So a final thought for our listeners maybe. Thinking about this as that instruction manual, perhaps the most important instruction is the need for constant vigilance and adaptability.
I think that's perfectly put. Vigilance in diagnosis, adaptability in treatment, and a commitment to lifelong learning because the challenges keep evolving, and so must our approaches to improve the lives of patients affected by vascular trauma.